Welcome back to the MI Mental Podcast, Doctors in Court edition. My name is Dr. Sabine Fonderson, a general practitioner, and this podcast looks at real medical cases that make their way to court. These cases aren't just cautionary tales, they're lessons about decision-making, ethics, and the consequences of our actions. Today, I'll dive into a tragic case involving a post-operative patient, inadequate anesthetic care, and the devastating aftermath. As usual, I'll be using made-up names, but the cases are real. This is the case of Mrs. June. She underwent a routine knee replacement surgery, but tragically passed away a month later due to post-operative complications. The case brings up critical issues around pain management, patient monitoring, and the role of communication between medical teams. Let me go straight to the story. Mrs. June was a 69-year-old woman scheduled for knee replacement surgery. Prior to the operation, she reported snoring and had been referred to a sleep specialist for suspected obstructive sleep apnea. Though the evaluation hadn't been completed yet, her medical history also included obesity, controlled hypertension, and thyroid surgery decades earlier. The surgery itself went well, but things started to unravel in the recovery room. Mrs. June complained of severe pain despite being given a patient-controlled analgesia, PCA, and that's a morphine pump. And over the next few hours, additional morphine was administered via her IV to manage her pain. In total, Mrs. June received 21 milligrams of morphine via the PCA pump and an additional 14 milligrams intravenously, so via the IV drain, and a substantial dose in total, especially for someone with her medical history. Shortly after being transferred to the orthopedic ward, she was found unresponsive by her family. Her tongue was protruding and she had frothy fluid around her mouth. Resuscitation efforts restored her heartbeat, but she suffered significant complications, including pneumonia, sepsis, and eventually passed away a month later. Mrs. June's sons filed a formal complaint against the anesthesiologist, Dr. Klein, and they accused him of negligence. They argued that excessive morphine doses were administered without adequate monitoring, and the staff failed to consider the impact of her likely sleep apnea on her ability to process opioids. The family also criticized the lack of communication. They alleged that Dr. Klein didn't properly oversee the use of the PCA pump and ignored warnings from the nursing staff when Mrs. June's condition started to deteriorate. The court ruled that Dr. Klein's actions violated professional standards of care in two critical areas. First, the total amount of morphine administered was deemed excessive, especially given Mrs. June's age, her obesity status, and potential sleep apnea. The anesthesiologist failed to adjust the pain management protocol to her specific risks. And the second area where the court ruled was that they found it was inadequate monitoring of the PCA pump. The court noted that Dr. Klein didn't ensure that the nursing staff were properly trained to manage the pump or monitor for opioid-related side effects like respiratory depression. However, the court found no evidence that Dr. Klein ignored alarm calls, as his shift had ended by the time the critical event occurred. Nonetheless, the lack of clear documentation and proactive communication contributed to the systemic failure. Ultimately, Dr. Klein was formally reprimanded for his role in Mrs. June's care, with the court emphasizing that pre-existing conditions like suspected sleep apnea must be factored into post-operative pain management plans. And this case highlights how critical it is to tailor pain management strategies to each patient. Morphine, while effective, carries significant risks, especially for patients with obesity or potential sleep apnea. Opioids can exacerbate hyperventilation, leading to dangerous levels of carbon dioxide buildup. And from an ethical standpoint, this case underscores the importance of vigilance. The family flagged concerns about Mrs. June's breathing post-operatively, but the system failed to act in time. It's a reminder that communication between healthcare teams is as important as clinical expertise. A 2024 review in Journal of Anesthesia and Pain Management highlights that patients with sleep apnea are at a significantly higher risk of opioid-induced respiratory depression. And the authors recommend alternative pain management strategies such as multimodal analgesia to reduce reliance on opioids in high-risk patients. And the study also emphasizes continuous monitoring for at least 24 hours post-operatively in patients receiving high-dose opioids. Tools like capnography can detect early signs of respiratory depression, potentially preventing catastrophic outcomes. This evidence reinforces the court's findings. Pain management protocols must prioritize safety, especially in patients with known or suspected vulnerabilities. What are some of the take-home messages from this case? Number 1, individualized pain management. We need to tailor opioid doses based on patient-specific risk factors like age, BMI, and sleep apnea. Number 2, proactive monitoring. We need to use continuous monitoring tools like pulse oximetry and capnography for at-risk patients. Number 3, collaborative communication. We need to ensure all team members are trained and informed about patient-specific risks. And for patients and family, it's important that they advocate for care. If something feels wrong, you need to speak up. Persistent advocacy can make a huge difference. And it's also important for patients and families to understand risk, and they need to be aware of how conditions like sleep apnea can increase the risk of certain treatment. Let me leave you with some thought-provoking questions. First, as a health professional, how do you balance effective pain management with minimizing risk for high-risk patients like Mrs. June? And would you have used opioids at all in her case? In my experience as a general practitioner, when it comes to pain management, especially in chronic pain, it's very important for me to assess all possible analgesias. And we use a protocol where we go through a sort of pain management ladder. So first, you always try non-opioid alternatives like paracetamol or NSAIDs, which are non-steroidal anti-inflammatory drugs. Or if that doesn't work, we can look at other options. But I typically only start opioids if all the other alternatives have not worked and I have looked at the patient risk, and I also want to see whether the patient has had an experience with it before. In my case, I've had many patients who even tell me, no, I don't want to use opioids because in the past, even a low dose gave them much more side effects. I must say that this case has really made me much more aware of comorbidities like sleep apnea, and I'll definitely take that into account when I consider introducing opioids for pain management. Question number 2, how can families advocate effectively in situations where they feel their concerns are being ignored? How do we ensure their voices are heard without creating conflict? As a medical doctor, I'm very happy when family members actually are present and are collaborative in the care management of their loved ones. What I think we definitely need to do more is give more space for family members to express their concerns, and family members should express observations clearly and frame their concerns in a way that is collaborative and not judgmental. For example, a family member can say, I'm noticing X. Could it mean something that we need to address? And if we learn to have that kind of conversation with each other, it means that we are going to be more respectful about what we want to do, and hopefully in the future it will ensure better outcomes. Before ending with this podcast, I want to leave you with before I leave you today with this case, I want to talk about a study published by Walker and colleagues in the Journal of Clinical Sleep Medicine in 2007 called Chronic Opioid Use is a Risk Factor for the Development of Central Sleep Apnea and Ataxic Breathing. The study explores the relationship between chronic opioid use and sleep-disordered breathing, focusing on central sleep apnea and ataxic breathing patterns. What the study shows is that chronic opioid users had a significantly higher apnea-hypoapnea index, AHI, compared to non-users, 43.5 versus 30.2 events per hour. And these findings were statistically significant. And central apnea events were notably more frequent in the opioid group, 12.8 versus 2.1 events per hour, underscoring opioids' impact on respiratory control. And a higher morphine equivalent dose correlated with increased central apneas and irregular breathing during non-rapid eye movement. And patients on more than 200 milligrams per day of morphine equivalent exhibited ataxic breathing in 92% of cases, compared to 5% in non-opioid users. There was also altered respiratory patterns in chronic opioid use, linking them to patterns like Bayer's respiration, ataxic breathing during non-rapid eye movement sleep, characterized by irregular breathing and pauses. And opioids appear to impair peripheral chemoreceptors in the carotid body, disrupting respiratory rhythm, regulating during sleep. So with this in mind and taking this into context, the study provides crucial insights into Mrs. June's case, where post-operative opioid use was a likely contributing factor to her fatal respiratory depression. And the court findings aligned the study's evidence, emphasizing the need for tailored opioid protocols and robust monitoring in at-risk patients like Mrs. June, who had suspected sleep apnea and additional risk factors, including her age, obesity, and previous surgery. What are the missed opportunity for proactive care? Mrs. June's case highlights the importance of recognizing patients with potential sleep disordered breathing when prescribing opioids, as central sleep apnea risk is heightened even at moderate opioid users. And monitoring deficiency. Again, as I mentioned earlier, continuous monitoring could have detected early signs of respiratory distress, especially given her known risk factors and the additional respiratory depressant effects of opioids. This case is a stark reminder of the stakes in medical care. Vigilance, communication, and proactive decision-making aren't just ideals, they are real necessities. Thank you for joining me on this episode on the MI Mental Podcast, Doctors in Court edition. Let's keep learning, let's keep improving for both ourselves and for our patients. See you next time.